Valentina. I'm a radiology student. I'm doing my knee trigger. So I have my tube detented to the table at 40 inches. The tube is centered with the IR. I have a 10 by 12 in the table bucky. I'm going to place my right marker right here. And I am ready to go get my patient. Hi. My name is Valentina from radiology. I'm going to be doing your exam today. What is? Can you verify your birthday for me?
March 31st, 1991.
And your full first name and last name.
And Gonzalez.
And what brings you here today?
I'm having right knee pain. Yeah.
Okay. Okay, so we'll be doing your knee x-rays today to
The right one.
the right one. Okay. And is there any chance of getting pregnant?
No.
Okay. So I'm going to have you come here to the table. And you can use the stool to get on the table. I can help you. So I'm going to have you lay down. And I'm going to put the shield on you. Okay. So now I'm going to see it on the center. I'm going to move my table. Can you scoot over that way a little bit? I mean, my bad, this way. Too much. Okay, perfect. Thank you. Okay, so my CR for AP knee is a half inch inferior to patellar apex. My clination is good around my heart. I'm going to use technique 70 at 6, and I'm going to go take my x-ray now. So you're going to hold still for me. X-ray. Okay. Okay, real good. I'm going to take the cassette down. I'm going to go read it. Okay, so I read it. I'm going to grab another one. Okay, so I have my cassette 10 by 12 in the table bucket for a peak medial rotation. I'm going to have my right marker in the corner. The tube is centered to the cassette, and it's also aligned at 40 inches with the table. Now I'm going to ask my patient to rotate your leg, the whole leg, medial 45 degrees. My central rate for this projection is taking place half inch inferior to patellar apex. So right here. And I'm ready to take an x-ray. Technique. Technique is 70 at 6. Okay. Okay, hold still. X-ray. So I'm going to take out my cassette. I'm going to go read it. I'll be right back for the next x-ray. Okay. So now I'm doing my medial lateral knee. I had my patient roll on their right side, which is an affected side. The left leg is over the right leg. The right knee is flexed 20 to 30 degrees. My tube is angled 5 to 7 degrees, cephalic. I use the sponge just to make them more comfortable and to have it more aligned, my epicondyles. My central rate for this lateral is directed to the knee joint and 1 inch distal to medial epicondyle, and the ankle is 5 to 7 scalp. I'm using 10 by 12 IR. I'm gonna put my right marker right here on the corner. center to the IR. So now I'm ready to take, oh no, technique is 70 at 6. Okay, now I'm gonna go take an x-ray. Okay, hold still, x-ray. Okay, now I'm gonna take the cassette out. You can relax. And I'm gonna go read the cassette. Okay, so now I am set up for my intercondylar fossa AP axial projection and the climb method. I use 10 by 12 IR. I put my portrait wise. I put my marker on the corner, right marker in the corner. I build up the, I decrease my OID by building it up more towards the knee, so it's closer to the knee. I ask my patient to flex the knee, the affected knee 60 degrees. My central ray for this projection is gonna go perpendicular to long axis of the tibia, entering the knee joint, half inch below the patellar apex. There is no tube angle for this one. My technique is gonna be 65/4 because we're using a non-graded cassette. And I think I'm ready to do the x-ray. Okay, hold still for me please. X-ray. Now I'm gonna go pick up my cassette. Alright, one side. Relax your leg. I'm gonna go read it. Okay, so I am set up to do my tangential projection of patella, Senegas method. I am using a 10 by 12 cassette. I put my marker on the lateral side, my right marker, since we're doing the right knee. My technique is 60 at 4 because it's not a grid cassette. I have a tube angle of 15 degrees to open up the patellofemoral joint. My central ray is gonna be perpendicular to the joint space below patella and femoral condyles, so right here. So it's gonna end here. And my patient is shielded. There's no marker. And I'm gonna go and take an x-ray now. I'll be right back.
Okay.
X-ray. Okay. I'm gonna get there. Very relaxed. I'm gonna go and read my cassette. Okay, now I'm gonna evaluate my knee images. This is AP projection of the right knee. We see femur, tibia, fibula, head of fibula, lateral condyle, medial condyle, patella, lateral epicondyle, medial epicondyle, lateral tibial plateau, medial tibial plateau, right here, intercondylar eminence, tuberosities, head of fibula, tibia fibula. The evaluation for this image is we need to have evidence of proper collimation, and I have that. It has to be adjusted to 10 by 12 inches size of on the collimator. I need to have knee fully extended if patient's condition permits. entire knee without rotation, and I know that if I have my femoral condyle symmetric and tibia intercondylar eminence centered, and I have that on my image, slight superimposition of the fibular head if the tibia is normal, and we have that too. Patella completely superimposed on the femur, and we have that too. And then I also have to have open femorotibial joint space with interspaces of equal width on both sides if the knee is normal, and we have that too. And this side it's a little bit more, it's a little bit closed up, but it's okay. And also soft tissue and bony trabecular detail, and we have that too. My central ray for this image is directed to a point half inch inferior to the patellar apex, and depending on the patient size, I would have to have a tube angle. If it's less than 19 centimeters, it would be 3 to 5 degrees caudad. If it's 19 to 24 centimeters, it would be perpendicular. So 0 degrees angle. If it would be more than 24 centimeters, it would be 3 to 5 degrees cephalad. So that's the AP projection of the right knee. And this is my AP oblique with medial rotation. We see patella, medial femoral condyle, lateral femoral condyle, medial tibial plateau, medial tibial condyle, lateral tibial condyle, tibiofibular articulation, fibula, tibia, femur. Evaluation criteria for this image is we have to have evidence of proper collimation, which is collimation has to be adjusted to 10 by 12 inches on the collimator. We have to have tibia and fibula separated at their proximal articulation. I have that here. I need to have posterior tibia right there. Lateral condyles of the femur and tibia. I have that too. Both tibial plateaus. We have that too. Margin of the patella projection slightly beyond the medial side of the femoral condyle. Also need to have an open knee joint and soft tissue and bony trabecular detail. My central ray for this image would be directed half inch inferior to the patellar apex, and the angle would also vary depending on the patient size. So that would be my AP oblique knee with medial rotation. And this is my medial lateral projection of the right knee. And we see femur and patella, femoral condyles, tibia, fibula, tibial plateau. The evaluation criteria for this image is we have to have proper collimation, which has to be adjusted to 10 by 12 inch on the collimator. The knee has to be flexed 20 to 30 degrees in lateral position, and we know that if we get femoral condyles superimposed over each other, and we have that here, even though they're a little bit off, I would have to flex the knee more to get them superimposed better. We have to have fibular head and tibia slightly superimposed, just like we have it here. patella and lateral profile. Open patellofemoral joint space. It's not really open on my image. Open joint space between femoral condyles and tibia. And soft tissue and boniotrabecular detail. And that would be my lateral medial lateral projection of the right knee. And this is my AP axial projection Beckler method. And we see femur, lateral condyle, medial condyle, intercondylar fossa, intercondylar eminence, tibia, and fibula. Evaluation criteria for this image is we have to have open intercondylar fossa, which we have that here, posterior inferior surface of the femoral condyles, we have that also, intercondylar eminence and the knee joint space, no superimposition of the fossa by the apex of the patella, we don't have that, no rotation, and we know we don't have a rotation if we get slight tibiofibular overlap. That's right here. And then we have to have soft tissue and boniotrabecular detail. Also, central ray for this projection would go perpendicular to the long axis of the lower leg, entering the knee joint ½ inch below the patellar apex. So that would be like right here. And that would be my AP axial projection of the right knee Beckler method, also called tunnel. Okay, and this is a tangential projection of the patella Sadagas method, also known as sunrise. On this image we see patella, patellofemoral condyle, lateral femoral condyle, medial femoral condyle, and fibula. Right here, fibula. Evaluation criteria for this image is we have to have evidence of proper collimation, which is has to be adjusted for to 10 by 12, 10 by 12 inch IR. Patella has to be in profile. Femoral condyles and intercondylar sulcus, we have that too. Open patellofemoral articulation and soft tissue and boniotrabecular detail, we have that, and that would be the criteria. Central ray for this image is perpendicular to the joint space between the patella and the femoral condyles, and the angulation of the tube is typically 15 to 20 degrees. Close collimation is recommended, and that would be my tangential projection of the patella.